And hi, everyone. TJ Aulds of I-45 Now. Welcome to another edition of Healthcare Unmasked, presented by UTMB Health. An exciting topic to talk to everyone here today. It is about telemedicine and telehealth, and we're going to be covering that topic in a wide array, not only in how UTMB was on the forefront of this, but also along the way of how it's being used these days, including not only to provide medical care, but also to assist in training others to do medical care across the country. And joining us today, we have Oliver Black, who is you talk about a guy who's been around for a good while of knowing this. He is the Senior Systems Analyst of Health Innovations at UTMB Health. Then Mary Robinson, she is the Director of UTMB Telehealth, and joining us a little bit later in the show is going to be Dr. Alex Perez, the mentoring surgery program head. He is going to be joining us as well to talk about exciting stuff that's happening with training surgeons and physicians across the country using this technology along the way as well. So we're going to have him on a little bit later in the show. But let me start off with Mary here. Mary, talk about, because really for when it comes to telemedicine, folks have gotten used to it now of being the virtual doctor visits and the like, but it's really not a new phenomena or a new system that's existed within UTMB, correct?
Right. UTMB was actually one of the people at the forefront of the teletechnology movement and started way back in the early 90s. That's quite a while now, several decades in. And they initially started out with a few local pilot projects, and then it just continually expanded. So now we have an enormous volume of telemedicine visits that we do, and they're all very unique and complex. And it's really worldwide and beyond, because we have telemedicine treatment centers down at the South Pole. We have them on the International Space Station. We've had telemedicine on cruise ships and across the continents to Africa and Asia, and even closer to home on things like oil rigs. So telemedicine has been around for a while now. It's just now starting to find its way into a broader applicability in Texas for all the patients that need it.
And one of the interesting things is that there was, you said by 2002, UTMB had 108 telemedicine sites located in 35 Texas cities there. Just so folks can understand just what is telemedicine, because I think folks have a different idea of how it was before it started and what it is now.
Sure. If you go back historically, telemedicine looks a lot like those old pictures that you see of computers that took up an entire room. Right. They had an entire station where there was a video broadcast and audio, and they had people on the other end doing examinations. And so telemedicine is a really specific term here in our state. It means to actually practice medicine using technology. And video technology is primarily what has been used by UTMB and folks trying to do higher level medicine. So there's a lot of really cool devices that will mimic the physical exam that a physician can do in their office. So it's really way, way beyond this idea of talking to someone on the telephone. It really is the forefront of medicine. And we have all kinds of devices that we're excited to show you later on in the presentation today. But it's way beyond just this sort of initial conversation that we saw a lot of during COVID out of sheer necessity.
And so in many ways, because of COVID, now when you look at it, in the last 10 years, UTMB has completed over 1.3 million telemedicine visits. What's been the pace like because of COVID? Because I know that one of the things I talked with Dr. Ben Raymer about this when we were starting to see late last summer, the kind of reopening of clinics and stuff, but also making sure that telemedicine was in place for the virtual visits, as I have done many times. But how much of a spike have we seen in the last year in that?
So it honestly really looks like a bell chart, and we're on the other side of the spike now. When COVID first happened, you started to see it sort of ramp up like this, and it went up really high, really fast. And now we're starting to sort of come back down. The experts are thinking that it's not going to be a true fall all the way back to where we were, and we're all very glad about that. But it will probably level off to where it is an integrated option. In other words, it's a choice that you have as a consumer as part of the medical care that you receive, but it is not intended to replace the medical care that you receive. So you should still have that great relationship with your UTMB doctor and see them in person when it's necessary, or once a year or once every 6 months, and possibly do follow-up visits or things like that virtually that make more sense, and can be done in a much less technology heightened setting. For example, let's say you got a rash and you don't know what's causing this allergy, or what's going on. And you go to your doctor and they take a look at it. They think they know what it is. They give you the prescription and you're supposed to follow up, right? We're all supposed to go back and follow up, but we have really, really busy lives. So that would be the type of appointment that's really ideal for telemedicine in that sense, because you can call back in, get on the video, say, hey, doc, look, it worked. I'm totally fine, and go along with your day. And your doctor is giving you great care, and you continue that relationship and you continue on without having to break up your day going in. But if you ever really have a significant problem, you're suffering from heart pain, or you have something that needs immediate in-person assistance, you still have that relationship there and can get the care that you need.
One of the things, and if those of you just joining us, you're watching Healthcare Unmasked, presented by UTMB here on I-45 now. And I have Mary Robinson, the director of UTMB Telehealth, and then we'll also have Oliver Black, the senior systems and analyst for health innovations at UTMB Health, on with us here. One of the things is it takes out that kind of that travel time too. I find that to be the most convenient part. Is I don't forgive him, and as you said, Mary, we have busy lives. But if I'm off somewhere and I'm 30 minutes away from the clinic where I need to have my visit, that having this be able to go into an office or go into stay at the house and have a visit with my medical provider, particularly on those things that a lot of times it's the doctor just taking information from you anyway. To decide what to do. It really does kind of speed up that kind of time frame and makes better use of the time of both patient and physician at this point.
Absolutely, that's the case. And so we're going to be going through a time frame where I think we figure out how to best make telemedicine a tool to incorporate into current medical practice. There will be times where it fits perfectly, and there will be times where you need to come in and see your doctor. And we'll be kind of learning all that together, right? As we come out of the pandemic time frame. And the technology available is really exciting, and it's going to make the ability to get really good information for your doctor even more available.
Also with us is Oliver Black. He is the senior systems analyst, I should say, of health innovations at UTMB Health. And Oliver's been around with this for a good while. As I say, I'm not trying to give you your age away here, Oliver. But can you just talk about how things have changed up technology wise, and then we're gonna go through some stuff with some folks to see the latest, but we're also gonna go back some as well. But just talk about how you've seen this evolve over the years.
Oh, when we started, the equipment was gigantic and expensive. It sat in a rack that was about 70 inches tall and weighed about 300 pounds. And really, we'd roll it into a room and it would have to sit in the corner, and there wasn't any movement. Peripherals were very rare, hard to find, and to broadcast the imagery and stuff. And so we had to do a lot of make do. We actually used a device was used by FM radio stations for broadcasting from the station out to the transmitter. We used that to broadcast our electronic stethoscopes through the digital circuits and stuff. And the switching, when we first started, there was no dial a phone number or click a thing, and literally we would get a call and we would run to a closet and unplug a jack and plug it into another one, and we started. That was in the TDCJ system in correctional managed care, and that's where we started. For switching, of course, we got lots of exercise going across campus, doing that about 5 times a day. And then, it progressed. Now, we're doing a broadcast with 4 or 5 people online, and then who knows how many hundreds others. And it's just a cheap, inexpensive, relatively speaking, subscription service. Back then, we had what's called a multi-point control unit when we started with automated switching, and five video conferences. Having capacity for 5 different systems was $500,000. And now, you Zoom and it's $10-15 a month.
Right. Yeah.
So,
The cost alone with it. I thought we'd bring this up to kind of, these are some of the images that Oliver has shown with us. And if you're just joining us, this is Healthcare Unmasked, talking about telemedicine and telehealth. Talk about this. This is the first time I came across UTMB Health work in telemedicine, and these are some folks set up at the South Pole of all places.
Yeah, that was my boss Jake Angelo and Dr. Stephen Villegas, who we were sent down there for the first visit just to look and see what they had when we started providing the telemedical services. Is the way we started with the South Pole stations. There's 3 of them. Here they're at the South Pole station, obviously with the UTMB flag. But we looked at it, and Jake actually had to fix their video system, which was kind of probably the longest service call ever registered at UTMB for the video team.
Yeah.
But it was an interesting thing. We had to set up a way to get the X-rays from there, because the biggest thing at the South Pole is slips and falls, and presumably because they have so much ice down there.
Yeah.
But we now deliver complete care. The docs and nursing staff and EMTs and everybody down there are all actually technically UTMB employees.
And there's also a bit of a challenge with that too. You're telling me how the satellites, you only have so much limited time and how it changes up.
Right. Yeah, we've got because of the way the Earth, their location, obviously, they only get about 12 hours of satellite time a day. And you have to check every time if you're going to make an appointment for telemed, because it changes 3 minutes every day. It moves. So we can't really automate like an EMR backup from the pole or anything like that, because you'll set it for 1 o'clock in the morning, and then 6 months from now, it's all of a sudden doesn't have any satellite time.
Right.
So we have to work around the schedule of the satellites. And the satellites, it's kind of interesting. Down here, they point up to the sky. There, they point to the horizon.
The horizon, yeah.
Is where the satellites are at for down there. They're using NASA GOES satellites primarily. So
it's fascinating that can take place, so far away with that too. And then we'll go on to the next photo here. Sorry, there we go. This is now this is a little bit of a different setup here. Tell us about this.
This was what we called the B30, and it was there were no portable telemedicine systems back around 1999, 2000, and we had some applications where they wanted to use them. So we took a airline capable suitcase and crammed as much telemedicine technology into it with a little 9-inch television screen. And it was neat because we had otoscope and a general view scope that we'll show some more modern versions here in a minute, electronic stethoscope. And the weight limit on airlines was at the time was 40 pounds for a carry-on. And this one came in right at 39.5. So we just squeezed it in there, and we're able to take systems like this literally around the world and connect back to the university for telemedicine services.
And then and this is a little different setup as well here. It's labeled Doc in a Box. So talk about this setup here.
That was our nickname. This is what we originally put in the correctional managed care sites. We built a total of 17 of them. They cost about $125,000 a pop. The codec was the size of a small refrigerator. The codec is the device that encodes and decodes all the audio and the video so we can stream it. They were just, at the time, it seemed like a lot of money, but they actually paid for themselves because now the TDCJ system did not have to transport all these patients back to Hospital Galveston to be seen. At the time, the university, for instance, there was a women's unit in Gatesville, the reception unit. Hello, welcome to prison. And they would have to do physicals on the women. They would have to fly about 7 docs once a week, at the cost of hundreds of thousands of dollars a year on a plane up to there. And they didn't, obviously, that was a huge money hole. And these systems that was one of the first units we put it in, and it stopped that travel and allowed them to conduct most of the exams and stuff remotely from UTMB.
And speaking of which, this is another example of using this for a telemedicine visit with one of the patients.
Yes, and this is no cameras are allowed in the prison system, so I took a picture of the television monitor with the image of, and this is someone having an eye examination with a slit lamp, and we had a camera on the slit lamp, and we could actually tie it into the system and broadcast that image back to Galveston. And of course, you can see the TDCJ prison guard right there. And this is later our BSL-4 lab. They're very interested in hemorrhagic fevers and all of these horrible diseases, which we hope never come here. And this was in Sierra Leone. We had just done a setup. They had outbreaks of Lassa fever, and we worked with Tulane University. They had a clinic out there, and we went out there, and you can see there's the B30 on the left. And they didn't have, when we were there was no Lassa fever. We went during the out of season to get it set up. And then, so they had a small child who had malaria, and just did a physical examination and sent it back to UTMB just to verify that everything would work. And there was no network or anything, so we found a satellite uplink that about the size of a paperback, which was remarkable at the time, and used that to get the signal back to Galveston. And that one, unfortunately, the clinic had to close when Ebola broke out there. Back a few years back, but it was, it was a good project while it lasted.
All right, and there's an interesting story. Speaking of Ebola, with this particular doctor that's performing the exam.
That's Dr. Umar Khan. He was in charge of that hospital in the clinic, and he was, when Ebola broke out, he was all over the country. Working on the patients that had the Ebola. Unfortunately, he also caught it and passed. With Ebola, it's one of the worst diseases to have, although we don't hear about it that much anymore. And the reason is I believe it was 2016, they finally developed a vaccine for it, and they've been vaccinating people in Sierra Leone and down in the Congo and places like that. And it's much less prevalent like it was. It used to be there were outbreaks, particularly down in the Democratic Republic of the Congo, just about every year. And it's really worked. The vaccine really helped that.
And Mary, this is something where telemedicine, you talk about, we're still trying to find ways to do it. This is where, and we'll talk about this in other capacities too, this is where telemedicine come in and get to remote locations, remote countries, to provide healthcare where otherwise it would be too expensive, or just the logistics of it just too great to make it work.
Yeah, absolutely. And quite frankly, we look a lot closer to home even with that. The project that Oliver and I are currently working on at UTMB is actually called the Virtual Health Network. And it's a UT system funded project to get all 8 of the medical campuses to be able to expand telemedicine out across the state of Texas to reach patients who really need that care. And particularly, we are focused on this idea of how do we get specialty care into underserved areas. So, you don't have to go, unfortunately, to Africa to find underserved areas where people really need health care and don't have a way to get it. And the technology has come so far that we can do cardiac exams, for example. Your town might be very small. There's no cardiologist for more than 200, 300 miles away. But we have been able to leverage technology to do those types of exams moving forward. So that is really, to me, the highest and best use of this technology is getting the care at a same high level that you and I would get in person, living in a city out to the areas that people don't have that same access, or for people who can't afford to take off 4 hours to drive across Houston, right, which round trip that could happen to do a follow-up visit. So a lot of this is about access and
Yeah.
keeping the care really high level still. So
Yeah, and we talk about the technology now and how exciting it was. I found this fascinating, Oliver. You sent this over to us earlier yesterday. This is from 1924.
Yeah.
Talk about this image. It was a magazine called Radio News. Everything radio back then. This is before televisions were invented, but someone was already envisioning a
Yeah,
telemedicine visit.
Hugo Gernsback, who the Hugo Technology Award that they give out for innovation every year. This was one of his magazines, and this was the first time I'd seen a concept this early of telemedicine. And you can see, using his imagination and some of the current technology then, you can see how he was very visionary. You've got the child on the left who is holding what it would have to be an electronic stethoscope to his chest, and the physician in the TV screen's looking at down his mouth as well. And I guess his brother and sister there also looking at it. And it's got a radio antenna. Obviously, they didn't have internet and digital switch systems and stuff back then. Everything was radio and the speaker. And then on the right, you can see what looks to be like an ECG printout coming out.
Yeah.
Of the system. So it's a remarkable drawing. I did read the text of it, and his writing style was crazy, as best I can tell. I could not understand it. But this drawing pretty much shows, like they say, a picture's worth 1,000 words.
It just shows that how sometimes you just envision it and then we can see it come to fruition at some point. Now we have today's technology. Doesn't anywhere look like that. I wonder if you can talk about that and show us some of what's used nowadays, Oliver.
Yeah, let me get it.
And those of you just joining us, this is UTMB Healthcare Unmasked, our monthly show here. We're talking about telemedicine. If you have questions, go ahead and put them in the comment section. We're going to have a Q&A session toward the end of the show here to get your questions answered.
All right.
And we'll bring you on up now.
There we go. Yeah, this is just a PowerPoint with some videos of some of the current technologies that we use. Obviously, UTMB primarily engages or has been until COVID in clinical telemedicine, where we have a specialist at UTMB reaching out to a remote clinic somewhere. So this gear is more professional than some of the stuff we're going to talk about later in this quick little PowerPoint show. But these are some medical cameras with different lenses. When found they have to be easy to use. Because a lot of times the presenters, the people who are using the equipment on the patient, may not use them for a few months because they're rotating different presenters through there. So we try and make them as easy as possible. as hospital as possible. If I could learn to speak, that would be great. They have multiple attachments that are available for them as well. This is a general view lens, so this allows the provider to look at specific areas of the body. And this is a video of how it in use with Scott, who works with us, Scott Mullen, Dr. Scott Mullen. So they do the focus. It's got a freeze frame button there. And once he presses it, boom, and that's the type of resolution of the image. You know, you can see all the little blood vessels and other items in the mouse as necessary. And it's also used for skin, some basic derm usages, and anything else that the doctor needs.
And let me ask you, Oliver, on when you have that camera that's in there, is that hooking up to another system, either via a Bluetooth or something like that, and then sending it on up to a physician that's on the other side?
Yeah, it's tied in. There's an HDMI output, just like what you use at home. So it's high definition, and it's tied into the video conferencing codec, that device that encodes all the audio and video, and sent to the physician. He's on a PC, just like probably most of you at home are, and he's looking at it live as they capture the image. And then also afterwards, if they want, they can plug that medical camera into their computer and upload it into the electronic medical record, so they can, here's what it looked like last month, and let's compare it to this month, et cetera. So it's still image capture, and it's also live video capable.
Gotcha. All right.
Yeah, the great part, just to throw in on that, the great part about this is much better than having to say, just write down irritated throat, right?
Right.
Now we know exactly what it looked like. So when they come back in the future, we have it. And you can even show the patient as the doctor, here are the things I'm concerned about. Look at this spot right here on your throat, you know, and you, the patient, can see it. That's also really great functionality that this type of equipment allows.
Yeah, and this is the otoscope. We're using the same camera handle. We're just switching lenses. Saves a lot of money. When we started, the salespeople wanted to sell us a complete camera system for each thing, but we realized we'd probably have a patient exam room filled with more equipment and what would allow people to fit in there. So we worked with this company in developing these systems, giving, you know, the doctors giving their opinions and ideas. So here's an otoscope lens. One of the neat things about this is that with a PD patient, for instance, a child, when they use this, it's hard enough just to get the instrument into a child who's moving around and fidgety and their ear hurts. With this, they can get in there, snap a picture, and pull out and be done much faster than with a normal one. And again, you get that same fantastic high definition imagery, and which again can be uploaded into the electronic medical record if desired.
And that's something I hadn't thought about with this, is that you get it done and it's over with, and you're not poking and prodding through there the whole time. For
Exactly.
any of the patients, it's a little bit, it's uncomfortable for a less amount of time for this type of visit.
Much better. And I get comments from the doctors that a lot of them say, you know, I can see this a lot better than I can with my regular handhold unit. So so this is a Fundus lens. This is for looking at the back of the eye, at the retina. We use this a lot when we have patients where there's elderly folks and they may have weight issues, and as such they may have diabetes, which can affect their eyes. And this literally, if you've ever had an ophthalmology exam, I've had a million of them because I wear glasses, and they dilate your eye, and then they take the image of the back of the eye. This thing doesn't need dilation, and it's usable by just about any med tech or nurse or PA. It's very easy to use. Let me get this.
Yeah, this is another one of those pieces of equipment that's really going to work to help bring ophthalmology consultation out into areas that wouldn't otherwise have it. And you know, folks with diabetes can get this done without having to go through that terrible thing where you put those orange colored drops in your eye and have to come back and all that stuff. So
yeah. And so this is the back of the eye. We'll do it again here real quick. When they're taking the picture, this is an interesting thing. They're actually aiming for that bright white spot, and you can sort of see the back of the eye. It uses infrared, so we're not using regular light in there. It's just detecting the heat on the back just to get it. And then when they push the capture button, boom, it sends just a 200 millisecond flash of light. So they're not sitting there holding a bright light into your eye for a couple of minutes while they get the image they want. It just pops and captures the image real quick. Some really neat high resolution imagery capabilities.
Well, and that's the thing is that we talk about, folks may talk about the technology that's out there, is that how small these devices are and how high resolution the imagery you get. I guess the best thing we can compare it to is somewhat like our cell phones can now shoot almost movie quality video. Is that it's the same technology in some ways?
Bingo, exactly. It's amazing, because our first stuff back in 93, 94, when we were started out, you had to be an octopus because it was like a standard optimal otoscope, and then they would put a camera unit on it, and it never lined up, and so you had to twist around, and it was always broken. At least that's what we would hear. We would go out there and no, it works fine because we had played with it enough, but the nurses and presenters had a real issue with it. And that's when we changed and moved to some more simpler stuff that was coming out at the time. And so if you've got, for the audience, if you've got a set of headphones or some earbuds with, if you want to put them on, we're going to listen in this one because this does not play well through your regular speakers. But if you do have headphones, go ahead and put them on and you can hear the heart sounds for what we're about to show. I'll give you a second to plug those in and
and then we're also and what I'm going to do here too is we'll turn off our mics for those of you that are not plugging in headphones along here. So and so you could, if you were listening here, you could hear the heartbeat through there. It was a little bit low there, but obviously if you have headphones in and it's just fascinating what can come through on these screens now.
Yeah, and I've got these slides. This is some stuff that I urge you to take caution. You can buy sort of some equipment on there with built-in cameras, but a lot of it is in my opinion dangerous and should not really be used. And I just want to go over some of the stuff. Like this is it's an oral camera, which is great for the kids, and then when you're done with the kids, then you can use it on your dog. This is a real ad that I found that I thought was particularly amusing. Just be careful what you're looking at. This is just a thermometer, but a red flag for me is when somebody puts the FDA logo on their website. That's actually against the law and it's against FDA regulations. And I actually checked this company's name in the FDA database, and it's not there. So this is in fact not FDA cleared at all. And then finally, this is one of the devices I was talking about, what I would consider a dangerous device. This thing is an otoscope, and it's got a little hook on it, little loop for cleaning out wax. It sounds great, but if you've been to the doctor's office and you see those cone-shaped otoscopes they use, that's there for a reason, to prevent you from being able to push it too far into the ear and prevent you from puncturing the eardrum. But this guy, you can see here, it could do that. It can just be it's just, I don't use it in my opinion. It's not that great, that device. And then finally, I've got some links here, and I think
we'll add these links to our site too. This is where because I want to talk to you a little bit about this, Oliver, because one of the things that happens here is that we have seen this, and Mary, you and I talked about this too, that in the emergence of when we moved to COVID, stuff going up, so many, the best I could call is quackery type of devices coming out. They could, heal you, cure you, prevent disease, prevent viruses and all. And it's not much different in this as we've gotten used to taking our own temperatures or doing, screening people or something like that, that these devices have come out and they're being pledged online as the cure-all for everything here at this time.
Yeah, the companies I've listed here are all fairly reputable. They are, shall we say, the good guys. They do sell FDA cleared devices. That bottom link, the access data, fda.gov, etc. That's where, if you're unsure, you can go there and you can put the manufacturer's name or the model number of the device, and you can check and see if it's in the FDA database. But yeah, there is a lot of stuff out there being sold. Before COVID, there was maybe, I don't know, 50 or 60 telemedicine, not just health providers, but services online. Now there are hundreds online. And so that, and it's like they popped up in February or March of last year. And it's just, to me, I was telling TJ earlier, I check and see, go do a who is and check and see when that website was created. To see how long they've been in business. To the best of my knowledge, for home use, there's only right now one set of devices that are actually FDA cleared by a company called Tyto Care units. You can buy them. You can buy them at Best Buy, but the problem is the physician has to have a license. And they won't show you the images. They'll only show the physician. So they kind of catch you in that proprietary system that you have to use the Tyto Care physicians. And then we don't know, in the state of Texas, and Mary can talk to this, the medical practice is where the patient is. And you have to be licensed in the state of Texas to see a patient in Texas.
Right. And the reasoning behind that is obvious, right? The state of Texas wants to make sure that the people providing medical care to its citizens are licensed and are trained, and you just can't believe what people will try to do. So this is right now, we are in a phase where it's going to take a while, like you said, TJ, for us to figure out exactly where everything fits and how it fits, because quite frankly, the standards and the law always lag behind where the envelope is being pushed. And so there's going to be great stuff coming out of this. A lot of stuff has already come out that's great. We will continue to deliver and create new ways to do this. I have no doubt that in 5 years, there will be a way to put, a drop of blood into something that right now looks like a diabetic, glucose level, but it'll run all kinds of batteries of tests back to your doctor. There's no doubt that technology will continue to exist. It's just consumers need to be really careful right now and try your best to develop a standing relationship with a provider that you feel comfortable with, and use telemedicine within that relationship so that they have your best interest at heart. They're not trying to make money off selling you a device. They're not trying to just quickly shuffle you in and charge you $50 for 20 minutes of a consultation, never give you any records, never see you again. So the consumer really has to be careful with this, because you're right. There's a lot of folks out there just trying to take advantage of the situation. So the best way to do that, because we're here with UTMB, is to, contact your UTMB provider, right?
Yeah. Go with your providers and understand, and then ask them, do you offer telemedicine or telehealth services, and go with the brand names you want to call it, whether it's UTMB or another institution that you feel comfortable with, and it comes along, because everyone's kind of rolling out different versions of telehealth right now. UTMB just happens to be at the forefront on that, and it's more than just treatment of patients. It's also being used in the training of that, and that brings us now to bring in Dr. Alex Perez. He is with Telementoring Surgery Program, and Dr. Perez, fascinating what you're working with right now, in that you're able to use this same technology now to work with doctors in training at all different levels, as well as surgeons who need continuing education on their studies. Can you talk about what you're working on?
Absolutely. And good afternoon, TJ. Thank you so much for this opportunity. I want to thank Mary and Oliver for their outstanding support. And most especially, I want to thank our UTMB president, Dr. Ben Raymer, whose support and leadership, without that, none of this would have been possible. In short, the natural extension of telemedicine is teleeducation. And UTMB has been at the forefront and has a legacy with education, being a leader nationally and internationally with regard to education. And so we were very fortunate to have that support and have this technology and these tools and all of that at this particular challenging time where COVID has created a distance between not only the healthcare provider and their patients, where telemedicine fits in, but also with regard to the distance between educator and learner. So that's where teleeducation fits in. And we were fortunate to create a new educational platform here at UTMB that has been very successful and that we've done through regional, national, and even international courses. And the success has been such that it's actually been even adopted by several societies worldwide to be a new platform for teaching others at every level. And so we've had experience with teaching people in the healthcare profession from every level, from medical student all the way up to very seasoned practitioners. We've also even been able to extend this to people outside of the healthcare profession, such as high school students who might be interested in potentially in the future joining the healthcare force. So it's also been a wonderful tool for diversity, equity, and inclusion. We've been able to reach out to underrepresented minorities in different areas of the United States, being able to bring to them opportunities to be able to practice suturing, getting mentorship one-to-one through this remote teleeducation and telementoring process. UTMB is blessed with a lot of expertise and world-class experts. And in the past, you were limited to geography. So patients were limited to the expertise that they had locally. Learners were limited to the expertise of their educators locally. Now we're able to provide that expertise that we have here at UTMB all across the U.S. and all across the world.
Let me ask along this lines too. Is that where do you see this in the near future of making differences? One of the things you explained to me is that you can actually teach, such as someone to work on sutures. Talk about how that process works.
Yeah, absolutely.
Hands-on.
Yeah, so we agree that everyone learns at a different pace in a different way. And some of us require visual, auditory, different pathways for learning, but there's also a necessity for hands-on learning. So you can imagine that the traditional courses that we're accustomed to is to have in-person group learning, and where you have your hands on a physical model where you practice on that model. And what we've done here at UTMB, which we've also led the way nationally, is created very realistic, high fidelity, low cost models that we ship out to our learners across the world. And so they'll have the model shipped to them with the equipment. They'll have it in front of them. They'll have the connections, the cameras, etc., so that we can connect with them one-to-one and then guide them through the process of step-by-step of how to do these different procedures. So we've done it with high school students with suturing, but we've also done it with seasoned surgeons who want to adapt to more minimally invasive surgical techniques, and that they don't have the local mentoring or expertise to do so.
And how have folks adapted to this type of training? I wonder, has it been slow in coming? Are we finding, because of the new generation of students, that this is actually a little more like secondhand to them?
This has absolutely been much more engaging. It's definitely speaking the language that they are familiar with. They are accustomed to having their phone and their laptop with them at all times. They're familiar with that system of communication. So we've just adapted to that environment. And the more that we're able to continuously adapt and to continuously live that life of continual quality improvement for our patients through lifelong education, I think we'll be able to continually be able to provide that high level of care.
And forgive me for this, Dr. Perez. I just want to pass along to anyone who may be watching right now some breaking news coming out of Texas City right now. A phoned-in threat to Texas City ISD. Several of the campuses in Texas City, in the city of Texas City, are on what's called a lockout. That means students stay in their classrooms and activities go as normal, but everyone stays inside. No one's allowed inside or out of those campuses right now. This is information just coming to us right now from Texas City ISD. And at this point, there's been no confirmation of any threat to any students at any of the campuses. At this point, Texas City Police, along with the Galveston County Sheriff's Office, investigating that. Sorry to interrupt you there, Dr. Perez, but we wanted to make sure we got that information out as soon as we got that from the school district here. Continuing on, we have coverage of that incident in Texas City going on right now. One of the things is that where do you see this being able to go in training of physicians and the like? You and I talked about this yesterday before we did the show, of that the underserved communities in our country, that this could be a game changer in so many ways. And can you delve into that some? I know you mentioned it before, but to delve into that a little deeper.
Yeah, absolutely. I think not only for learners, but also for patients. You can imagine that it's no surprise that the outcomes for patients that go to specialty centers that specialize in their particular type of disease have better outcomes. The same thing with the ability to teach and to learn in an environment which is familiar with that and expert in that, the outcomes for that are superior. So to be able to have this local expertise and be able to package it up and send it out throughout the world and have patients benefit from it directly, because there are examples of surgeries that are performed across continents. So this is something that it's the tip of the iceberg. It's the beginning. I think that we have many opportunities to continuously adapt and grow, and UTMB has been at the forefront. And again, because of that legacy of education and of excellence in clinical care, we are very proud to be leading that charge.
And I find it too. This was something I brought up as some of the stories I've worked on along the way, is that the students that are coming up now, and you seem super excited to be able to talk about high school students. You mentioned it, teaching them, because you can build that next round of doctors and nurses even along the way by getting to them early, and that this technology actually helps you get to that forefront a lot quicker than, say, through HOSA, which a lot of folks are familiar with in the high school level. I just see, where do you see that going on that education purpose of building a new, I would say, medical workforce? Yeah,
absolutely. I think we're reaching out, and the response has been tremendous. I think now that information is disseminated widely, the barriers for access are been diminished. I think we have still a lot of room for improvement, but I think there's a culture of awareness that we need to reach out. We need to set the example. We need to show our population, our young students, our future healthcare providers, that that we are here to support them, and that they have a tremendous future where they can truly contribute. And so, being able to engage in this platform and reach across to all of these future healthcare providers, and to do it in such a way that they're taught also in an interprofessional education environment. So it's not the silos of the past where you're training in a very specific subfield and you never interact with, let's say, if you're in surgery, you don't interact with the nursing team and all of the rest of the team. You can imagine there's so many people in that team. Now we believe and understand that we have to begin that interprofessional education from the very beginning. So if you're a high school student and you're in a class of other high school students and you want to take care of patients as your future, you understand that you can access this from many different pathways, and that regardless of how you do it, we work as a team, and that the earlier we get to starting with this and the more support and more networking that we can create, the more successful and the stronger the foundation will be to provide that care for our patients.
And we're going to bring Mary and Oliver back in with us here now, as we've got a few minutes left in the show for any questions that you may have. Go ahead and put them in the comment section there on Facebook or Twitter or YouTube. One that popped up here I thought was great, though it's not really a question so much. This is Jill Resendez. She said, I had surgery and then televisit the day after. I thought it was great. Didn't have to go anywhere, and the doctor was able to see the incisions and see the work just fine. Really convenient. Mary, that's the whole point here of that, is that it's a tool. She went in for the surgery, and after you've had surgery, the last thing I really want to do is go back into a visit, take a drive or something like that. I'd like to just stay home. She was able to do that and work with her physician.
Yeah, that's exactly a perfect use case. 100% exactly what we love to see, because saved her a trip, allowed her physician probably to see more patients, which is always good for patient access. And if she had needed something, if something was going south, she would have had a way to go back and get what she needed because she had that relationship. So it sounds great. It sounds like it worked exactly like it was supposed to.
Yeah. Dr. Perez, I know you have a session to go to at 1:00. Last question I want to be able to ask you before you duck out here is that where do you see this going? Give me your crystal ball here in as far as the training purposes and being able to mentor 5 to 10 years down the road of using this technology.
So I see that this will be the new method for training. So instead of matching to one medical school where you train for 4 years and then matching to a residency where you might train for 5 to 10 years and then go off into practice, what this will allow you to have is an access to a repository of world-class experts who will be willing to follow you along, and that you'll be able to access throughout, sort of like a continuous stream of expertise. Right now, the way the educational system is that you are expected to learn everything during those very finite blocks of time, and then just practice what you learned 10, 20, 30 years ago. Instead of saying we are constantly evolving, learning more. And that really goes to the core of the mission at UTMB, which is not just the clinical care, but also education and research, so that continuum of growth and expansion will always allow our patients to get the best possible care.
So the days of the doctors having to go off to a conference at a far away resort could go away at this point.
Absolutely. So, for example, right now, access, costs, time, all limit your ability or desire to really access that. So if you're in practice, being able to do that is very hard. Right now, I chair a group at the American College of Surgeons, which is the world's largest group of surgeons. And our committee is in charge of the continuing education of surgeons in practice. And so we are using this methodology and others to create that culture of being able to continuously teach our surgeons already in practice of the latest techniques and tools, so that patients throughout the U.S. and the world will be able to get the standard of care no matter where they are geographically.
Dr. Perez, we do appreciate you coming on. I know you have a hard deadline at 1. I wanted to make sure. Is there anything else you wanted to share with us before you step away?
No, sir. I appreciate this opportunity, and I really want to thank the support at UTMB. It's tremendous, and thank you very much.
Great. Thanks, Dr. Alex Perez. And if you're a budding surgeon, this is the guy you'll be helping. He'll be helping you out through UTMB Health and maybe via a telemedicine setup. So thanks for coming on with us. We appreciate you. Mary, let me ask this. We've had a question from one of our viewers here, Scott Thompson. It says, what treatments are available via telemedicine right now? And Oliver, you can chime in on this too. Right now, is it limited really, or is the sky the limit right now?
So the limit is sort of the standard of care, right? What can you do that will allow you as a doctor to meet the standard of care for whatever the condition is? So, for example, if you're diagnosing something that requires a swab test of your throat, you're still going to need that swab test, but you not have to go to the doctor's office to do it. There might be a closer clinical location you can go do that. Your doctor can get your results. It's really more limited by what each doctor and each practice wants to incorporate than what the technology will allow right now. So you need to find a practice that you're comfortable with and that has the offerings you want. But almost everything that is, traditional care outside of surgical procedures, right, which need to be done in person right now, but pre-op for that, post-op for that, a lot of those things are all being incorporated into virtual settings. So it's close to the sky's the limit as long as we can mimic the information that the physician needs to treat the patient, then it's going to be appropriate. So it's just a matter of finding which practice fits what you need and wants to do those things.
And Oliver,
from a technical standpoint, if we can figure out a camera system and integrate that into the system, or like this electronic stethoscope, we can do it. The only thing really they cannot do at this point in time is touch. You can't palpate the belly or something like that. So what they've done is they have the presenter there, the nurse or the PA or medical assistant, and they will palpate the person as an example and tell them what they're feeling. If it's something more specific, we've sometimes actually brought them in for specialized training in that palpation of whatever the doctor specializes in, and then sent them back out to get those results. I did do some research a few years back to see if there was anything available. MIT was working on something, it's called haptic feedback. But the sad thing about it was that about 90% of all of the haptic feedback is being currently applied to games and gaming, sitting in those seats that vibrate and stuff like that. And it was, other than the MIT project, that was about the only thing that I had found that was doing the physical touch.
Yeah, and I guess Apple Watches too right now. That's kind of the newer technology that's going to be rolling out with the Apple Watches. Is that technology as well? Again, but it, as you say, it could go on to those next phases as folks get used to it. It's been a fascinating topic to talk to y'all. I want to follow up with y'all on this, and maybe next time around we get a chance to also maybe we'll get a couple of patients who will volunteer to show how a telemedicine visit would be. I'm glad we did have the videos that Oliver had for us as well. Before we wrap up here, Oliver, any final thoughts of that? I think you covered a lot, but that folks should have a better understanding, particularly as we go in the technology aspects. You've seen it all from the early days on. Not now, and I don't want to date you too much here. You weren't around when the 1924 magazine came out, so I just give you a break.
No, he clearly started his training, in like elementary school.
Right.
He's just been doing it a long time, really early.
Yeah,
absolutely.
I mean, I'm amazed constantly at, like we talked about earlier, the size of things, how they shrink down. The telemedicine cameras, the resolution, things get smaller, they get cheaper, just like almost anything that's technological that we work with is, I can remember in high school, the teacher, you can't use a calculator. What, you think you're going to have a calculator everywhere? And, we've got a whole computer system in our hands nowadays. It's just amazing. I'm looking forward to, working more now that people know more about telehealth, to providing more systems out there, like in the colonias along the Texas border and places like that, where there are no doctors, maybe a nurse if you're lucky. Yeah.
And I think, if anything, that's the exciting part of this is, Mary, you and I talked, one of the early setups of this was UTMB setting up to work with rural hospitals in the first place, was to get healthcare where it was needed. I'm going to ask you to put your lawyer hat on, though, for a second here, because this is one thing that I'm sure will come up. what do we see as the ethical dilemmas that may come from this that could have legalities as well as the ethics side of things down the road on telemedicine? I think about it like I had a telemedicine visit and the doctor told me this, and the next thing you know, that's not what it was. And if we not insisted on that, I mean, I'm sure those are the things we're trying to figure out right now of how to apply this.
There's a few kind of ethical situations that could arise that, doctors really do need to be cautious of. But it's similar to the ones that already exist. So, for example, if you have a patient who is trying to insist on a telehealth visit when you, as the physician, believe there's no way it's appropriate for this specific scenario, unfortunately, you as the physician are going to have to be the one to say, no, you have to come to the office. But we see that already with patients who come in and say, I saw this commercial for this drug and it's the one I want. And the doctor has to be the one to say, well, that might not be appropriate. So, I mean, it's certainly going to be a challenge when people come to expect, on demand access, because there will be times where it's absolutely the right solution and there will be times where it is absolutely not.
Right.
And so getting that line sort of drawn is going to be challenging, particularly when it's the providers who have to draw that line. The other challenge that I see is what you just talked about, TJ, this idea of follow-up, right? So there already are a lot of setups where they're going to just house a bunch of doctors in the middle of nowhere, and they're going to get them licensed in Texas, but those doctors aren't in Texas, and they're just going to take video calls and you'll never see that doctor again. And, how do you follow up when something goes wrong? What if you need to be admitted to the hospital? Who's going to do that? Because you don't have those relationships, and you can show up at the emergency room, but they don't know who you are. They don't know what prior treatment you got. So continuity of care is really going to be important. To the degree that we use telemedicine to keep good continuity of care and keep good relationships, there's a real danger just to use it as a patch job, right? And I get it, because life is difficult and medicine's expensive, but we need to find a way to try to avoid that trap as well. So those are the two sort of most immediate things that I see being a challenge. And of course, we're still arguing over who's going to pay for it. That argument's still happening at a federal level, at a state level, because the great thing about access is more people get medical, but the expensive thing about access is more people get medical care.
Yeah. And one of the things too on that subject, as Dr. Ben Raymer and I spoke about this last year, was how do you charge for an insurance, the insurance side of things on a visit? What's the copay? There's a lot that has to be kind of worked through, and the regulatory approvals you have to have, and insurance companies say, well, that doesn't count as a real visit. It's just by phone or by video instead of in person. This is not, it's changing the system along the way. But again, I think it goes to what you said at first, Mary, is that this needs to be treated as a tool and not a replacement. And
Exactly.
that may be the best thing along the way. And you brought up a good point, and I can only think about these hubs where these doctors just are kind of in the middle of nowhere, just virtual, gone away. It's kind of like telemarketing reverse, going the other way around. When you call in, you're just going to get a random person along the way, and you have no idea what their credentials are with that. It's been a great topic. Thank you, Mary Robinson and Oliver Black. Mary is the director of UTMB Telehealth. And then Oliver Black, the Senior Systems Analyst for Health Innovations at UTMB Health. And we also want to thank Dr. Alex Perez, who is doing some wonderful things on mentoring and tele-mentoring for surgery along the way. And I know he was really excited talking about that subject when we talked today and, of course, yesterday as well. Thank you all for joining us, and make sure you join us next month. We haven't picked out the topic yet. We're working on that now. We think we have a couple of ideas, but we'll tell you about that a little bit later. For those watching, as you heard about our breaking news, again, Texas City ISD has put several of its campuses on what's called a hold. And in this case, there is that because of a phone-in tip. At this point, there has been no confirmation of a threat to students at this time. But at several campuses in Texas City ISD, particularly in the city of Texas City right now, those campuses are on hold. That means no one in, no one out, but classes are underway as normal, as they would be. It's not a lockdown right now at those campuses, and they are checking those. And right now, there has been no evidence of that threat being credible. Mary, thanks for coming on. Oliver, appreciate you as well.
Thank you.
I'm
Thank
TJ
you.
Aulds, I-45 Now.